Hello everyone, my name is Vish, and today I'm going to be walking through the assessment and treatment of unconscious or altered mental status patients. Let's set the scene. You're sitting, enjoying a nice slow day in the UEMR office, dozing off, looking at Scott's wonderful face and wondering why it looks like that, when suddenly you get a call. You're dispatched to a 20-year-old female with difficulty breathing located at the community garden and notified that RFD is en route to the call. When you arrive, this is what you see. Great difficulty breathing there, dispatch. What are we thinking about now that we have an apparently unconscious patient? The acronym or the mnemonic that we use to assess and think about what to assess in unconscious or altered mental status is AEIOU-TIPS. AEIOU-TIPS covers a range of etiologies that could be the cause of your patient's altered or unconscious state. When you get a patient like this, think about whether they're using alcohol or drugs or have a acidotic metabolism or other acidosis, whether there's some sort of epileptic, endocrine, electrolyte, or encephalopathic cause, whether your patient could be having an infection or could be in septic shock, whether your patient is having an oxygen deficiency, whether having difficulty breathing, or having poisoning such as cyanide or carbon monoxide, or whether they overdosed on drugs or other medications, whether they've underdosed, for example, haven't taken enough of a medication that they have been taking for a long period, such as could happen in alcohol withdrawal, whether there's a traumatic cause, as if they were knocked unconscious, if there's an insulin or diabetic emergency, does the patient have low blood sugar, whether there's some sort of psychogenic or pharmacologic or poisoning cause of the altered mental status or unconsciousness, or whether the patient is in shock, could possibly have had a stroke, a seizure, or a syncopal episode. So what do you do when you come up on an unconscious patient? Well, the first things first, EMT schools drilled this into all of us. You need to control the CABCs and keep your patient alive. Is your patient breathing? Does she have a pulse? What's the skin look like? Provide CPR if you've got to, if the patient's pulseless. You need to provide airway support if the patient is not breathing adequately, or non-rebreather if it looks like the patient isn't perfusing properly or has some sort of oxygen deficiency. And make sure you control the C-spine if you suspect a spinal trauma or traumatic mechanism of injury. So what do we see for our female patient at the community gardens? She's breathing, but she's only breathing at a rate of 6. Her pulse is weak and really rapid. She's responsive to pain. She has facial swelling and hives, and her friend tells you that she was out here working with the garden and then suddenly started itching and then said she was having trouble breathing and then she collapsed a few minutes ago. Well, it's time to fix this. Keep our patient alive. Our patient isn't breathing well enough. She's only got 6 respirations per minute. We'll need to breathe for her. We'll need to give her ventilation using a bag valve mask. And we need to see if there's some sort of addressable cause that's causing our patient to be unconscious and not have adequate vitals to maintain consciousness and other functions. Is there possibly like a reversible cause because we carry naloxone and epinephrine? Does she have signs of opiate abuse? Is there drug paraphernalia? Probably not. In this case, she's out in the garden, she's working, she says she's itching. We need to suspect an anaphylactic exposure. We see hives, and we see evidence of lowered BP, so it's time to administer epinephrine. If the patient comes back, or if you have enough people, see if you can get a blood glucose. Otherwise, maintain breathing, maintain her airway, keep checking your pulse, and assessing until you can hand over and continue care with RFD. What do we do with the altered mental status? The same things apply. AEIOU-TIPS. We assess all the same things because some of the same causes of unconsciousness are also the root causes of altered mental status. So let's do a second round. This time we're dispatched to a patient with an unknown medical issue sitting in the dining hall west kitchen. She's sitting on the floor and she's responsive to us but confused. She's able to follow our directions and answer some basic questions, but she doesn't really seem oriented with what's going on, and she's not completely coherent. You do a quick head to toe and you see no signs of trauma, and she seems to be 45 or in her 40s. So what are we thinking about so far? Well, we haven't really gotten a lot to rule out any of our AEIOU-TIPS options. She could have taken alcohol or some other drugs and theirs altered because of that. She could have had a seizure and she's altered because she's postictal. Our patient could be infection, could have like some stage of septic shock. Our patient could be having a stroke. She could be having a hypoglycemic emergency. And there's a couple other causes like endocrine, encephalopathy, some electrolyte stuff. She could be poisoned or have an acidosis. Or as a last resort, a psychological issue. Now, why do I say that psychological issues are last resort? Well, whenever you're dealing with an unconscious or an altered mental status patient, you want to assume that the psychological issue is the least likely option. You really need to rule out all the other more serious options before you even begin to consider that the patient could be altered because of a psychological issue. If you miss any of these because you assume that the patient is having some sort of like depressive or panic attack or psychological breakdown or something like that, that's not good. Your patient is going to deteriorate. You're not giving them the proper treatment. So let's see what our patient's vitals are. She's really hypertensive and tachycardic. But her SpO2 and her blood glucose are acceptable. And her bystanders tell us that this seems to have happened within like the last 30 minutes. So let's start assessing. What are we thinking about? She could still have taken some drugs and had a seizure. She could also have some endocrine or any of these other issues. But let's assess for some of the most serious stuff first. What if she's had a stroke? We'll conduct the Cincinnati pre-hospital assessment. In this case, we'll say the patient has gotten some right arm drift. According to protocol, we tell RFD that the stroke alert and then our last known normal was within 24 hours. So we conduct the LA motor scale. We tell RFD that our patient has scored a 1 for arm drift and a 1 for grip strength on the LA motor scale. And we continue monitoring and supporting our patient's vitals until we transfer to RFD. So what other considerations do we have when we're assessing altered or unconscious patients in the field? Altered and unconscious patients are some very difficult patients. If they're unconscious, you can't ask them any questions, and there's a big part of our assessment just lost to the wind, and we have to somehow obtain the information from bystanders if there are any. But even if they're only altered and not unconscious, the history isn't fully reliable. It can be incomplete. The patient might be too altered to obtain their history, or in some cases false. They could forget something. They could be confused. They could possibly not completely understand what you're saying. So when we're assessing these patients, we need to be suspicious of all the possible causes. Rule out everything that you can in AEIOU-TIPS. Give RFD what's left, and make sure that we keep our patients in good shape as long as we can. We especially don't want to assume that causes of altered mental status are due to one thing or the other. Or what if we get an altered patient and our patient or his friends report that they were consuming alcohol? We can't just assume that the patient's altered because he's drunk. We have to make sure we rule out other important causes, such as the patient could be having a diabetic emergency or some other allergic reaction or something similar to that. And finally, while this might be more rare, There are a couple other extenuating circumstances that can be increasingly important in altered or unconscious patients, especially when there's few to no bystanders that know what happened. There's a couple of environmental causes that could cause such a status. If there's asphyxiant gases, the patient is in an environment without oxygen or low levels of oxygen, that could be a cause of unconsciousness. Or if the patient is suffering from carbon monoxide poisoning, this could also be a cause of unconsciousness. So these types of calls are indications to be especially aware of what could be possible environmental causes, because we do not want to walk into asphyxiating atmospheres or get carbon monoxide poisoning. So be wary when you're in things like closed lab spaces or in the steam tunnels or drainage culverts or areas like that, because these could be areas where the atmosphere might not be things that the atmosphere might not be what we need to breathe. And finally, and just to beat a dead horse, always be thorough with these patients. You really don't want to miss anything, and even if you can't rule out everything, you should at least be able to rule out some of the things and hopefully be able to provide more supportive care, or at least some more useful information to Richardson Fire Department when you hand these patients off. This has been a review on how to assess and treat patients who are altered, have an altered mental status, or patients who are unconscious. If you have any questions after reviewing our protocols or running practice calls, please don't hesitate to talk to your peers, talk to your captains, talk to your UEMR leadership, and ask for more training. Unconscious or altered patients are incredibly difficult to treat properly and not miss anything, so make sure you get your practice in so you can be a confident and competent EMT in the field.